Thanks, Linda. You are in fact handing over to me. We're just going to now reassemble all the speakers. If you've got any questions coming out of any of the presentations, if I could ask all the speakers to come up to the top table, grab a pew and a glass of water. And so for the next 15 minutes, if you'd like to fire away with questions. And I get to be David Dimbleby, but there'll be no mentioning of Indie Ref for the next 15 minutes at least. Somebody want water? Okay, so any questions, ladies and gentlemen?
Yes or no?
Other than that one. Yes, Brian.
So Brian Robson, Healthcare Improvement Scotland.
Hi.
That was great. It was a super, outline of how the progress has been made over the years. Linda, I'm really struck by your story, both your story and that of your registrar, where you knew something, you had knowledge. Okay, you might have held back a little bit because of some of your knowledge, but you had knowledge that allowed you to trigger something to improve the chances of your child doing well. How do we get that knowledge upstream? How are we doing that to get the public more aware?
So I think the public are aware.
Do better fight across all the programs.
Yeah, I think for both of us, we recognise if we had been normal members of the public, our children would have been in hospital earlier. And I think that's actually the bottom line of it. I think we stalled because both of us are sitting saying children are febrile and tachycardic, children are febrile and tachycardic, and we know that, and we know that most of what we see out of ours is actually fine and has a virus and goes home, and our job is to differentiate. So actually both of us stayed at home to differentiate. Both of our kids were pretty sick when they came in. Neither of us are particularly proud of that, but we're happy to share the story of it. But I think the public do know. So actually there's absolute terror in the public about sepsis. There's not a single parent doesn't know. And generally it's about meningococcal sepsis, but actually the symptoms are the same for whatever bacteria it is. Symptoms are often the same for flu. So actually more children die of viral sepsis than bacterial sepsis in the UK every year. So people do know about that and actually present early. And I think we are left with this kind of split of actually almost, reassuring the normal, but actually escalating the kids that we are worried about. And my main worry about the sepsis 6 is actually how we can control is not the right word, but restrict it so that actually every febrile tachycardic child in primary care doesn't come in having had pre-hospital antibiotics, which is committing them to a whole new risk actually, and the sort of antimicrobial stewardship side of things more than anything else. So I think we were probably bad examples. I think that the moral of that story is don't have paediatricians as your parent, to be honest. So I don't, late presentations, I don't know how you feel, Con, but late presentation is actually really unusual. So kids presenting an absolute overwhelming sepsis because they've been kept at home for too long is actually really, really unusual in the UK.
Paediatrics is discrimination in this.
Yeah.
For every 100 febrile tachycardic children we'll see is identified with 1 or 2 septic ones. That's the big problem. And most of the mortality in the developing world is actually from late presentation.
Yeah.
Most of the kids who die in India, Africa, wherever, it's because they presented much later than a child would here.
Yeah. So, I mean, it's unusual for us to see
pews
late.
will help though, with regards to identifying a sick patient. So, I've got experience of being a parent as well. My child ended up in the hospital and the triage nurse running down the corridor with me, and I went to see the out of hours, and I got told to give him rehydration salts, and if he's not better, take him to the hospital in the morning. And it was before I went to work in York for a while, and I put him in my hand to put him in the chair, and the child was floppy like that. And and if I had sat at home with that and not gone, he would have, I'm fairly sure he'd been unwell because he was, he got 30 mils per kilo of fluid when he came into hospital. So I do think any tool we can have to help people in primary care to say, this is a snotty child, this isn't a snotty child.
Yeah, I mean, I think the difficulty with pews, I mean, we're all using pews. It's not that we're not using one, we're just trying to standardise it across the country, so we're all using the same one. We're all using them, and pews is a tool, and all of us have seen children die with pews of 0.
Yeah.
And that's the difficulty, is actually it's even less sensitive than it is an adult.
I guess if that were true, Linda, it would
Yeah.
need to feed, would it?
Yeah.
If the public knew more about sepsis. So it might be for kids that we are all as parents concerned with meningitis and temperatures, and we are so, but it's not, as a GP, it's not my experience that the public and patients really know much about sepsis.
So,
it's only recently the GPs have started to use the word sepsis in referral, and it's made a huge difference to getting patients through the pathway quicker.
Give my own story as an ICU physician. I was in Canada 2 years ago as a senior fellow. I got cellulitis in my leg, sitting at home, having taken some probably inappropriate oral antibiotics that were out of date, that were in my bag, and I felt my pulse, and I had a heart rate of about 140. So, my pulse is really racing, febrile. I thought maybe I should get myself to A&E. So, if you can't recognise it yourself, I think it's quite hard to get the knowledge upstream.
So is that one of the key difficulties, and this goes out to all the panel then, is it the fact that there's got to be slightly subtly different messages, not just between secondary care and primary care, but depending on the age and the situation of the patient?
I think an awareness, and be a child, a pregnant mother, or be a 70-year-old, who's confused from an acute urinary tract infection, I think is an awareness that when you're feeling unwell, and that the slurred speech, fever, rigors, tachycardia, all these things are actually go and see your doctor, and actually rather than don't sit at home, because I work in an area that's probably towards the lower class end of the spectrum, and people come in, it's whatever you think's right, doc, and I don't want to bother you, and they present in extremis, be them an adult or a child, and again we still see you. I send you sick children all the time, and they usually do present like, So it's I think awareness raising is needed, personally.
Okay, thanks very much for that question. Any more questions, ladies and gentlemen? Yes.
I'm struck by the case that you described of the 28-year-old lady who knowingly decided to stay within a local unit, but the structure that was put in place in terms of identification, communication, and that structured communication to Ninewells, there was a whole teamwork element to that. What kind of support did you give to both teams to enable that to happen?
It was just actually the raising awareness, even with the midwifery units, around, because they have women, they're not expecting women to become ill, they're not within the high risk area. Also at the time, we now use the early warning system regardless of place in Tayside, so even within the midwifery units, but they still do the observations according to low risk protocols. So even before that, it was still important to have the midwives aware of the sepsis tool, so we still went out and did the teaching around that, just the awareness of it, I think, and especially because this history of temperatures for women wasn't really taken. It was taken as, well, that's just what happens, you're working hard and you get, and you're thinking, really, every time you go to the gym, you get a temp of 38.5. Gosh, I'm not going to go there, so that kind of thing. So we really had to kind of try and get people to be really thinking of the picture. And of course, these midwives were, they were thinking, well, actually, this woman is, ideally, this wouldn't be her recommended place of birth. So they were just a little bit more vigilant with that, and using the SBAR communication. So we really wanted to be really clear about what you were thinking when you phoned. So it was about the assessment, so the tool is, you might trigger the tool. It doesn't necessarily mean to say you'll go on and do the sepsis 6, but you need to trigger the assessment, which we thought was the most important thing, and have someone think about the whole picture before they would then go on and say, right, okay, I'm going to make this 0 hour and we're going from now. So it was, and we've had some good examples of that from the midwifery units. Some not so good, but mostly good.
Okay, we probably get time for about another one, possibly 2 questions, very quickly. Anybody else? Yes, lady in the middle there.
It's to Linda again. Can I ask, in Dundee, have you developed a guideline for how you de-escalate treatment of your septic women? Because it's in my unit, it's quite variable how the length of time they have the antibiotics and then what follow-up they have when they go home.
We haven't yet, and that's the very thing that we're in the middle of just now. You know, it's still varied depending on what and I think it will be to a certain extent, because it will depend sometimes on what will happen afterwards. You know, so some women will very quickly, everything will resolve, the blood results will come back, you know, but at least I think we're looking at the tool of saying, like, say 6 hours later, you know, so by that time you've got more observations, you've got all your blood results back, maybe not blood cultures, but you've got enough of a better picture of what you need to do. So I think in the tool we're going to put, like, I think a 6 hour and a 12-hour review or a 24-hour review. I'm not quite sure how that's, you know, exactly what they want, but I think that's the bit we need next, you know, and making sure that on a daily basis there is a review from a consultant, rather than, you know, say a trainee or a more junior doctor. You know, there is a consultant review at that time to say, we are happy that this is enough antibiotics, or we need to continue with it, or what is the plan, and wanting specific plans rather than just little one-liners within notes, you know, so very clear plans around antibiotic use. Yeah, so not yet, but that's what we're working on.
Okay, just room for last very quick question, if anybody has one, preferably one that could be answered yes or no, but not not that one. Anyone else? Going once? Going twice? Okay, thanks very much. Thank you very much to everybody on the panel.